for this complication? What kind of positioning do you use? Do you use face down positioning? And if so, for how many days? Or do you use nasal side positioning for the inverted flap? I saw you do. And please tell us more about the viscous elastic covering of a flap. Do you aspirate it? I assume you don't aspirate it at the end because it will dislocate the flap as well.
Thanks very much for your question. As you said, that the biggest complication associated with the use of armature membrane is the dislocation. So we try to solve those problems. In the past, we just use a injection of either use a viscoelastic or use a whole blood. Whole blood works better because whole blood forms like a blood clot and sealed it so that the armature membrane will not move. But it's also a very laborious procedure for the patient, also invasive procedure. So we improve this procedure by injecting it under perforate carbon liquid. So this is a technique developed by our colleague called SPOT technique. It has been published in the literature. And basically, if you inject under perforate carbon liquid, it forms like a ball of gel. It will not disperse. So once the gel touches the retinal surface, become a ball. So it would help stabilize the armature membrane in place. So after this technique, we rarely found the displacement of the armature membrane.
And after you aspirate the PVCL at the end, the viscoelastic will stay as a bubble?
Yeah, it stays over there. I don't aspirate it. And I usually ask the patient to adopt a supine position for 1 day, then adopt the prone position afterward.
Okay, thank you. Thank you.
Corollary to that, how are you doing the exchange at that point? So you have it under OVD, right? And so how are you removing the PFCL? You're doing it doing air exchange?
Yeah, then I proceed with an air-free change, then aspirate the fluid and carefully. So that because right now you have perforate carbon liquid, right? So you aspirate from the peripheral. So the perforate carbon liquid would be aspirated gradually, then to the border of the gel. Then we'll stop it.
Thank you.
Thank you. I have 2 quick questions for Dr. Kusaka. During the procedure, if you can identify the outer leaf break, would you still deroof the schisis, or would you drain through the schisis? That's the first question. And the second question is, in a small group of patients similar to the ones you showed, in 2 cases, I found that post-operatively, the macular schisis improved. Did you notice that in your cases, and what do you think the mechanism is?
Yes, thank you very much for these are very important questions. As for the second question, the improvement of macular schisis, I also found in some cases, but I didn't look at my record very systematically, so I didn't present the case, my data in this presentation. But I think you are right. There are some papers from China that out of 27 eyes, there was some improvement of the macular schisis